PCOS. I was diagnosed with PCOS, and the woman with PCOS was diagnosed with polycystic ovaries and PCOS. At the age of 15, I had a 3 week or over 3 weeks of seeing a very heavy period. And the 5 years prior to that, I was experiencing irregular periods, hair loss, weight gain, acne, skin discoloration, thick facial hair, low moods, and sugar craving and fatigue. Prior to the diagnosis, my symptoms elevated blood sugar levels, severe pains in my lower abdomen, facial hairs, just feeling very, very unwell, depressed, anxiety, panic and period. It's still normal. Managing that is very difficult. My day-to-day obstacle, constant obstacle would be my weight gain. I'm getting my weight under control. That is very challenging. Challenge acne, excessive oil and skin, and excessive hair growth in certain places. At the time, I had a period in more than a year. I had weight gain that was extremely difficult, if impossible to me. And I was very scared because what was explained to me was that I would have these symptoms the rest of my life. It's lifelong. And there may be issues with becoming pregnant if I am ready to become a mother. It was extremely overwhelming, and I was extremely scared. This had the biggest impact on my life was depression. I was so overwhelmed at the time. I just never went back because I was like, I can't afford surgery. Having a community of other women with PCOS to kind of bounce things off of to give me suggestions that I can take back to my medical team to try. After having 17 years with PCOS, dealing with infertility and hair on my face, menstrual cycles that were irregular, pain, I finally feel like I'm on top of everything. So my advice or suggestion to anybody with PCOS is always, find community because we are best advocates and we do the best, I think, in terms of educating and supporting and advising. And you need to seek advice only because early detection can help with the PCOS on the countries. I found PCOS challenge, and after having an opportunity to attend symposiums and run 5Ks and talk with doctors as the journalist who asked questions for just not myself but other women, I was able to really get to the bottom of my symptoms and kind of naturally treat them. And my hope for the future for PCOS is that we can do a better job of identifying the symptoms of diagnosing and coming up with treatments that actually work so that women can come about better quality of something.
Dean, Faculty of Science and Technology at the University of the West Indies, Dr. Brian Coburno, Deputy Dean, Graduate Studies and Researcher, Faculty of Medical Sciences, Professor Dilip Dan, Head, Department of Basic Veterinary Sciences, School of Veterinary Medicine, here at the Faculty of Medical Sciences, Dr. Venkatesan Sundaram, guest speaker, Professor Ricardo Aziz, Director for PCOS Challenge, Ms. Sasha Uti, Rotary District Governor, Zones of 70, 30, and 7020, Mr. Brian Glasgow, President for the Diabetes Association of Trinidad and Tobago, Mr. Andrew Danhu, and the participants joining us from various countries. Good afternoon. Welcome to our webinar, Increasing Awareness on Polycystic Ovary in Trinidad. Before we begin, let's take a moment to establish protocol to ensure a smooth and productive session. Here are a few guidelines to keep in mind throughout the webinar. A French channel is being offered, so please use the interpretation button to choose French. Mute your microphones and keep your cameras off unless when speaking. Feel free to utilize the chat feature to ask questions, share insights, or even engage in discussions. Our moderators will keep a close eye on the chair and address your queries at the appropriate intervals. If you wish to contribute to the conversation or have a specific question, please raise your hand and our team will give you the opportunity to speak. We encourage an open and inclusive environment where diverse viewpoints are welcome. Let's engage in respectful dialogue and create an atmosphere conducive to learning and sharing. Our agenda is thoughtfully designed to cover essential topics within the allocated time. So let's adhere to the schedule to make sure that we make most of this event. Embrace this unique opportunity to connect with experts, peers, and like-minded individuals. Once again, thank you for being part of this webinar. Polycystic ovary syndrome, also referred to as PCOS, is a common health problem resulting from an imbalance of reproductive hormones and thus affecting 1 in every 10 women. PCOS is also considered as the leading cause of global infertility. The prevalence of PCOS varies among different countries, and this has prompted myself, my team of researchers, to embark on assessing its occurrence in Trinidad for the first time ever. Throughout our study, we noticed a common misunderstanding of the condition. What are the symptoms? What causes PCOS? Can I still get pregnant? Are there other health problems linked to it? How is PCOS diagnosed? How is it treated? These are just some of the burning questions that women frequently encounter. This evening, we have gathered to address these questions and to shed light on the condition. I'd first like to take the opportunity to welcome the Deputy Dean for Graduate Studies and Research here at the Faculty of Medical Sciences to bring greetings, Professor Dilip Dan. In addition to his role, he serves as a Senior Medical Officer and holds the esteemed title of Professor of Surgery. Professor Dan has made significant contributions to the field of laparoscopic surgery and bariatric surgery. I now invite Professor Dilip Dan to give greetings.
Hi, good evening, and thank you for inviting me. For the sake of preservation of time, and with a long list of specially invited guests, each deserving of special mention, may I just say, all protocols observed. It gives me great pleasure to bring opening remarks on this very important webinar aimed at increasing the awareness of a very common challenge for young women in Trinidad and Tobago and the wider Caribbean. Polycystic ovarian syndrome has become extremely common, especially with the rise of childhood obesity and obesity in general. We are facing an obesity epidemic, with 30% of our kids being considered severely overweight or obese. These obese kids will turn out to be obese adults, even though the symptoms of polycystic ovarian syndrome are clearly noticed in the teenage years with hirsutism and irregular periods. It becomes even more evident when our young ladies face infertility when trying to conceive. And we also see the long-term consequences with diabetes, hypertension, and endometrial cancer as well. This webinar is very timely as it brings awareness to this dreaded, highly prevalent problem. I would really like, on behalf of the Dean of the Faculty of Medical Sciences, Professor Terence Simangal, and the incoming Dean, Professor Hariharan Sitaraman, to congratulate the organizers of this webinar and the investigators, both from the Faculty of Science and Technology and the Department of Veterinary, the School of Veterinary Medicine and the Faculty of Medical Sciences. I would like to wish you all success in this event, not only in identifying the prevalence of the problem, which we know is high, but more importantly, to make an impact on the lifestyle and weight management, which is probably the most crucial aspect of managing this problem. So I wish you all the best in this webinar and in this study and in the future management of this dreaded condition. Thank you very much.
Thank you, Professor Dilip. Our next person to bring greetings is Mr. Brian Glasgow. He is the Rotary District 7030 Governor for 2023 to 2024, overseeing 75 Rotary clubs across 17 countries. With a strong Rotary background, including past presidency and significant contributions, Brian's leadership is backed up by his expertise as a highly qualified accountant with an MSc in finance. He also holds prestigious titles, including serving as a commissioner on the Regional Judicial Legal Services Commission of the Caribbean Court of Justice and chairman of the Fiscal Responsibility Mechanism of St. Vincent and the Grenadines. Beyond Rotary, Brian's public service extends to his role as honorary consultant of Sweden and positions on various boards. As district governor, his priorities include eradicating polio, empowering girls and women, promoting diversity and inclusion, and addressing mental health challenges. I now welcome Mr. Brian Glasgow to give greetings.
Thank you, Professor Mohammed. Distinguished panelists, guests, and fellow members of the Rotary family. I am deeply honored to be at this groundbreaking regional webinar on advancing women's health through PCOS awareness. This exceptional collaboration between the University of the West Indies St. Augustine campus and 3 Rotary clubs, the Rotary clubs of Central Port of Spain, Felicity, Charleville, St. Augustine, as well as RAMPS Logistics and Caribbean Eye Institute, truly exemplifies the power of collective action for an essential cause. Allow me to emphasize that this webinar aligns perfectly with Rotary International's Empowering Girls and Mental Health presidential initiatives, as well as our own steadfast commitment to disease prevention and treatment. By raising awareness about PCOS, we can address its significant impact on women's health, not just locally, but throughout the entire Caribbean region and beyond. It is crucial to recognize that PCOS is not merely an endocrine disorder, but also a risk factor for vascular disease, leading to severe complications like type 2 diabetes. And, astonishingly, by age 40, 50% of women with PCOS develop this condition. That's according to the Center of Disease Control and Prevention. And we must also mention the increased risk of mental health issues, such as depression and anxiety. Shedding light on PCOS allows us to contribute to early detection, timely intervention, and improved outcomes for countless women. Today, we are fortunate to have an internationally esteemed panel of presenters who will share their expertise and insights. Professor Ricardo Aziz and Ms. Sasha Otti. Their knowledge and unwavering passion will undoubtedly ignite inspiration within us all. I also want to acknowledge the dedicated research team who have made significant contributions to this field. Yourself, Dr. Mohammed, Dr. Venkatasan Sundaram, and Dr. Brian Coburn. And it would be remiss of me if I did not mention here that Dr. Sundaram holds a special place in the Rotary family, having been a former Rotaractor. I urge every participant to actively engage in this webinar, absorb the valuable information and knowledge which will be shared, and become ambassadors for PCOS. Encourage awareness in your respective communities, because together we possess the power to create a tangible difference in the lives of women. And together we must encourage women who suffer from this disease. I extend my wishes for a productive and enlightening session ahead. Thank you. Thank you very much.
Thank you, Mr. Brian Glasgow. Next, I would like to introduce you all to Mr. Dan Hu. Mr. Dan Hu is currently the president of the Diabetes Association of Trinidad and Tobago, serving his second term in office and serving the DATT for the past 8 years. He is also the director of the Trinidad and Tobago NCD Alliance, and he serves on the Ministry of Health's Food Advisory Committee. Mr. Andrew Dan Hu is currently a doctoral candidate at the UWI here at St. Augustine campus. His work involves investigating non-invasive diabetes screening and testing methods, which is of particular interest in screening children for diabetes risk. I would now invite Mr. Andrew Dan Hu to give greetings on behalf of the Diabetes Association for Trinidad and Tobago.
Thank you, Dr. Mohammed, and thank you for the invitation. I want to say a special good afternoon to all of the representatives from throughout the Caribbean, Rotarians, and of course from the University of West Indies. I'm really honored to address you all this afternoon at the opening of this webinar. Of course, aiming to raise awareness of polycystic ovary syndrome, PCOS, as we call it in Trinidad, PCOS, some persons do. As the president of the Diabetes Association, it brings me great pleasure to see such enthusiasm and interest in this topic, as it affects so many women in Trinidad and Tobago, and of course around the Caribbean. Firstly, I would like to extend gratitude to you, Dr. Mohammed, because for the invitation and for inviting the Diabetes Association to participate in the work and the research that you are doing. As many of us would know and would hear more about today about PCOS. PCOS is a common and complex hormonal disorder that affects women of reproductive age. It's imperative that we increase awareness about this condition to facilitate increased detection, better care, and improved outcomes for these women. Women with PCOS can develop serious health problems, especially if they are overweight. As we just heard from the district governor, more than half of women in the United States with PCOS go on to develop type 2 diabetes by the age of 40. And I would say, I suspect that in the Caribbean, this figure may be higher. And I know that some of that will be revealed later on with your work. Additionally, those with PCOS are at risk for developing gestational diabetes. And this not just affects the woman during the pregnancy and of course the baby, but it also puts both the woman and the baby at risk for developing type 2 diabetes later in life. The connection between PCOS and diabetes lies with the shared underlying factors, chief of which is insulin resistance. Individuals with PCOS often struggle with struggle managing insulin, leading to elevated blood sugars and an increased risk of diabetes over time. Moreover, the unhealthy distribution of fat commonly seen in PCOS further exacerbates insulin resistance and raises a woman's risk for type 2 diabetes. As the Diabetes Association of Trinidad and Tobago, it's our responsibility to advocate for comprehensive healthcare that includes early detection, education, and management of both PCOS and diabetes. We must work collaboratively with healthcare professionals, with policymakers, and with groups such as this, hosting the session today to ensure that women with PCOS are screened regularly for diabetes risk factors. With this in mind, we recently started nutritional counseling for women with PCOS at the Diabetes Association. And I must say, we are oversubscribed and we actually booked up for the next few weeks for this service. Effective lifestyle interventions such as balanced diet, regular exercise, and weight management are crucial for both the prevention and management of PCOS and diabetes. By providing women with the necessary information and support, we empower them to take care of their health and reduce their risk of developing serious complications. In closing, I commend each one of you for your commitment to this cause, just by attending this session today. Together, we can make a profound impact on the health and well-being of these women in Trinidad and Tobago and, of course, across the Caribbean. So I wish you a very productive and enlightening webinar ahead. Thank you. Thanks for the invitation.
Thank you, Mr. Andrew Danaher. Now, I would like to introduce to you Dr. Venkatesan Sundaram, Head for the Department of Basic Veterinary Sciences at the School of Veterinary Medicine, Faculty of Medical Sciences. He's a distinguished translational researcher, and his primary focus is on reproductive biology in animal models, aligning with the One Health concept. Over the last 6 years, he has been an invaluable guide in my investigations into PCOS animal models. Currently, he actively mentors me and our team in studying the prevalence of polycystic ovarian syndrome in Trinidad. With an impressive academic journey, Dr. Sundaram earned his master's and doctorate under a prestigious government merit-based scholarship at Tamil Nadu Veterinary and Animal Sciences University, Chennai in India. He boasts 24 years of teaching and research experience and has been recognized with the esteemed Young Scientist Teaching Award for his significant contributions. He has been successful in securing multiple research grants during his tenure here at the UWI, with 72 publications, all of scientific research publications. He demonstrates expertise in reproductive biology and comparative vertebrate morphology. Dr. Venkatesan Sundaram's commitment to research and education continues to have a profound impact on the scientific community and beyond, solidifying his position as a leading figure in his field. Dr. Venkatesan Sundaram will now introduce a very special person here tonight. Dr. Sundaram.
Thank you, Ms. Stephanie Mohammed, for giving a chance for me to introduce Ms. Sasa Oti. So Ms. Sasa Oti is the founder and executive director of the PCOS Challenge, the National Polycystic Ovary Syndrome Association, the leading 501c3 support and patient advocacy organization globally that is advancing the cause for women and girls with PCOS. Ms. Sasa started the organization after she diagnosed with PCOS and experienced great dissatisfaction with the availability of support resources for the woman with the condition. Under Ms. Sasa's leadership, PCOS Challenge has quickly grown to over 55,000 members and helped many women overcome their struggles with infertility, weight gain, anxiety, depression, and reduce their risk for numerous life-threatening related diseases. As Executive Director of the PCOS Challenge, Ms. Sasa built a coalition of over 70 major national and international health organizations and lead the first successful legislative advocacy effort in the US Congress to recognize the seriousness of the PCOS, the need for the further research, improved treatment and care options, and for a cure for PCOS, and to designate September as PCOS Awareness Month. Misasa also created the PCOS Awareness Symposium, the largest event globally dedicated to the polycystic ovarian syndrome, which has educated thousands of patients and healthcare professionals about PCOS since 2013. In 2018, Misasa helped to organize the first international conference on PCOS in India for both patients and healthcare providers. Through PCOS Challenge, Misasa has helped to develop one of the largest multimedia bodies of educational content dedicated to PCOS, which includes television, radio, print, and online resources. Misasa is the executive producer of the national award-winning cable television series, the PCOS Challenge. She is also the host of the PCOS Challenge radio show and publisher of PCOS Challenge magazine. Misasa is a clinical and research microbiologist with a bachelor's degree in clinical laboratory science from Harvard University and a master's in health administration from the University of the Phoenix. Prior to founding PCOS Challenge, Misasa was a contract research microbiologist at the National Institute of Health. So I invite Ms. Sasa.
Thank you so much. Thank you, Dr. Sundaram, for that introduction. And thank you to the organizers for inviting me to present at this this wonderful and much needed event. I will share my screen. So, as you just heard, my name is Sasha Ati. I'm founder and executive director of PCOS Challenge, the National Polycystic Ovary Syndrome Association. I was born in Jamaica and currently live in the United States. And like many of you, our stories are similar, where I got diagnosed and felt alone, felt up to my own, like I needed to figure out how to treat myself and how to support myself with this disorder. Hence why PCOS Challenge was founded. Yes, one person can make a difference. I used my PCOS diagnosis as a defining moment to create
Apologies, I believe that we have a slight connection problem.
doctor, including hair. Can you hear me?
Yes, Ms. Sasha, you're okay to go now?
All right, thank you. So if you look back, most people with PCOS experience some symptoms in their teenage years. That's I was no different. But upon the diagnosis and after reading that little pamphlet that took me 5 minutes to read and didn't give me much information, and my doctor telling me to come back to see her when I want to get pregnant, I felt dismissed, and I experienced the firsthand impact of the limited support resources and access to quality care for PCOS. So this quote inspired me. I always wondered why somebody doesn't do something about that, and then I realized that I was somebody. I'll just share a little bit about PCOS Challenge, where the U.S. National Polycystic Ovary Syndrome Association and the largest support and advocacy organization globally for people with PCOS, and we serve nearly 60,000 people. Our mission is to raise public awareness about PCOS and help others with the disorder overcome their symptoms and reduce their risk for life-threatening conditions such as type 2 diabetes, stroke, cardiovascular disease, and cancer. Our short-term vision is that PCOS is treated as a public health priority, but we aspire to find a cure for the disorder. I know, we aspire to work toward that goal. We have 6 major program areas: awareness, support and empowerment, education, because without education, and education is the key for us to feel more empowered to advocate for ourselves and understand how to find the best solutions for us. We are very strong on advocacy. We believe that using our stories to create change is the only way that will create a brighter future for PCOS, for people with PCOS. And access to care, as you heard before from the speakers before, is essential to achieving that goal. And research is what drives improved healthcare and improved treatment options. So we run national campaigns throughout the US and internationally, and we're very pleased to work with Doctors Mohammed, Coburn, and Sundaram as a part of our team on this research project that led by Dr. Stephanie Mohammed to understand the prevalence of PCOS in Trinidad and Tobago. We have the PCOS Awareness Symposium, which educates patients and healthcare providers and the community every year. And that's in September during PCOS Awareness Month. And please go to PCOSchallenge.org to get more information, or sign up at PCOSchallenge.com to stay up to date with the latest happenings. And the driver of change is advocacy. And when we found out, we were trying to figure out why PCOS, which was such a prevalent disorder, why it didn't have the resources, why there was so many gaps in care. And the fact was there wasn't an advocacy force. So that's why PCOS Challenge built the PCOS advocacy platform to do things such as recognize September as PCOS Awareness Month, to create World PCOS Day, to create these opportunities for people around and stakeholders around the world to elevate the message about PCOS and the need for change. So these are our advocates in action. This is Capitol Hill. You'll see the current Vice President of the United States. So we literally go to legislators and speak about how PCOS impacts constituents, but the change that's made here also resonates around the world. And so we're very excited to be a part of this effort and join with the team to help to raise PCOS awareness. And this year, 2023, the theme for PCOS Awareness Month is the empowered patient. So I'll just quickly go through because we're short on time. PCOS Awareness Month this year, we have themes. Week 1, the first week of September, begins with September World PCOS Day. And we have themes throughout the entire month, from support, fertility, lifestyle, and adolescent health. There are some resources. There are some resources from Caribbean organizations in Barbados, in Jamaica, Trinidad. There's the PCOS project there. And there's some other support and nutrition and exercise resources here that I have for you. However, please join us at PCOSchallenge.org. Please know that you are not alone. PCOS is one of the most common human disorders. And so, so much change can happen. So much can happen when we don't feel alone and we work together to help to change the future for everyone with PCOS. Thank you.
Thank you, Ms. Sasha Uti, for that lovely presentation. And thank you, Dr. Venkatesan Sundaram as well, too, for introducing Mrs. Uti. For persons that are interested in PCOS Challenge, it is a free website. We will have the organizers insert it into the chat box so you can actually go directly to the link. Our next person is to bring greetings. He is currently serving as the Dean for the Faculty of Science and Technology. He has a career spanning over 20 years at the University of the West Indies here at the St. Augustine campus. His diverse roles include serving as the head of the Department of Life Sciences, Deputy Dean, Enterprise, Development and Outreach, Faculty of Science and Agriculture, and as the public orator for the St. Augustine campus. Additionally, Dr. Coburn holds the position of second vice president for the Diabetes Association of Trinidad and Tobago. Dr. Coburn's research endeavors centers around the development of non-invasive techniques for diabetes mellitus assessment with a goal of enhancing awareness and fostering effective screening initiatives in the community. As insulin resistance and type 2 diabetes have associations with polycystic ovary syndrome, Dr. Coburn plays an important role as one of the investigators on this current project in which it is we are assessing the prevalence of polycystic ovary syndrome in Trinidad. To introduce our guest speaker, I now invite Dr. Brian Coburn.
Thank you, Dr. Mohammed. Verifying that you can hear me?
Yes, Dean.
Okay, colleagues, ladies and gentlemen, good afternoon or good evening, wherever you might be, including a warm thank you to those very courageous ladies in our opening video testimonials. Ricardo Aziz, MD, MPH, MBA, is an internationally recognized physician, scientist, and executive. His biomedical research focuses on the study of androgen excess disorders, having published over 500 original peer-reviewed articles, book chapters, and reviews. He's a member of the editorial board of the Journal of Clinical Endocrinology and Metabolism, and has served as senior editor of eLife. He's also served as Chief Science Officer and EVP Operations, Strategy, and Scientific Affairs for the Lundquist Institute for Biomedical Innovation at Harvard, UCLA, as Deputy Director, Clinical and Translational Sciences Institute, and Assistant Dean, Clinical and Translational Sciences at UCLA. He also previously served as Chief Officer of Academic Health and Hospital Affairs, State University of New York, as founding president of Georgia Regents University, now known as Augusta University, as president of Georgia Health Sciences University, as founding CEO and chair of the Georgia Regents Health System, and as chair of the boards of directors of the Georgia Regents Medical Center and of the Roosevelt Warm Springs Rehabilitation and Specialty Hospitals. Among other advisory capacities, he has served on multiple NIH committees, chaired the U.S. FDA Advisory Board on Reproductive Health Drugs, and served on the Oversight Committee for the California Institute for Regenerative Medicine. He has received, among other recognitions, the 2000 President's Achievement Award of the Society for Gynecological Investigation, elected member of the Association of American Physicians, and is recipient of the 2014 Alumni Fellow Award of the Pennsylvania State University Alumni Association. He serves as faculty in the departments of obstetrics and gynecology and medicine at the Hare-Sink School of Medicine in the Department of Healthcare Organization and Policy in the School of Public Health, University of Alabama at Birmingham. We are fortunate to have Professor Aziz directing the research effort into polycystic ovary syndrome in Trinidad, and here today to lend his gravitas to this initiative to raise awareness here. Ladies and gentlemen, here is our featured speaker, Professor Ricardo Aziz.
Dr. Coburn, that was very kind and very generous. I appreciate it very much. When I hear those introductions, I always wish my mother would listen to those, but I'll have to record one of those and do that. But thank you. You're very kind. And thank you, Dr. Sundaram. And thank you very particularly, Stephanie Mohammed. You have been a driving force in this, and I know it's not been easy. Thank you to the Rotary as well as the Diabetes Association because it's very important to have this support. What my task today is, and you've heard from some incredible speakers, my good friend Sasha Oti, and her as a driving force for PCOS Challenge. I have studied polycystic ovary syndrome for some 35 years, and this is what I've dedicated my life career to. I'll share a little bit of this, of what I know, and we'll hopefully open it to questions to both Sasha and myself, and then we'll be able to do that. Let me start out by sharing the slides and make sure that everything is able to be shared. Okay. And let's see here. How are we doing? Can you see me?
Seeing you very clearly.
Very good. And you see the slides. Fantastic. Thank you, Dr. Coburn. So the key messages that I want you to take home today, and again, if you learn nothing else from myself other than these messages, this will be more than enough. PCOS is very common. In fact, my team many years ago was the first worldwide to report on the prevalence of polycystic ovary syndrome, and we'll talk a little bit more about it. And you are not alone. This is not a rare disorder. This is not an uncommon disorder. It's unfortunately an under-recognized disorder, which is something that we are working toward eliminating, and that's something that Sasha and Stephanie and others are doing. PCOS can have features that change over the long term. This is not a static disorder over time. PCOS affects individuals differently, and treatments need to be tailored. This is not one size fits all. You know, there are short-term and long-term health impacts. PCOS is not just a cosmetic disorder, not just a reproductive disorder, not just a insulin-resistant disorder. It's all of those things and much more. Education and support are vital to better health outcomes. We want you and others to be educated, to know as much as we do or more. Treatment can reduce symptoms and the risk of later complications, and there are treatments. And so we would like to make sure that you are aware of it. Lifestyle management improves all aspects of PCOS, but again, not everybody is a candidate for lifestyle management, and not everybody will benefit equally. Effective treatments are available, including when you wish to have a family or a pregnancy. So these are some of the messages, and then we'll go back into the details. But again, this is all I would like you to take home today, if nothing else. So what is polycystic ovary syndrome? Well, polycystic ovary syndrome is a syndrome, for starters. It means a collection of signs and features. It's not a specific disorder. It's not like one test tells you what you have. It's a collection of features. It's a hormone metabolic reproductive condition with many features, as we'll see in a minute. It affects up to 1 in 7 women of childbearing age. And so we need to understand that it's evident in women of childbearing age, but it is a lifelong disorder. So while it's most evident in women of childbearing age, it is a lifelong disorder and it affects a great many women. As I said, anywhere between 1 in 10 and 1 in 7 women. The cause is both inherited and lifestyle related, although inheritance plays a significant role. It tends to run in families, as many other things do, right? Diabetes, heart disease, breast cancer, etc. So it's not surprising that it runs in families. It means that if you have PCOS, then your sister may have a higher risk for that, or your mother, or your daughter, etc. There are 3 types of hormones that I'm going to speak about as being principally involved in PCOS: androgens, insulin, and LH. There are many others, anti-Mullerian hormone, AMH, these kind of things. But right now, we are going to focus on 3 of them so that it helps you understand what PCOS is. Now, the PCOS diagnosis really involves, 2 out of 3 signs or symptoms, right? One of them is irregular ovulation or absent ovulation. And this generally is translated into irregular menstruation, right? But again, menstruation is not a perfect marker for ovulation, but in general, that's what we use clinically. So abnormal ovulation is the first sort of feature of polycystic ovary syndrome in many women. The second is excess male hormones or excess male hormone effect. You don't actually have to have elevated levels of male hormones, but you have the effects of male hormones. For example, excess male-like hair growth, which we call hirsutism. In some individuals, it may have higher levels of androgens, male hormones in the blood. And so on and so forth. So excess androgens, or what we call hyperandrogenism, is another feature. A third feature is what we call polycystic ovaries. This is where the disorder got its name, because many years ago, really about 80 to 90 years ago, when this was described for the first time in 1935, the only way that you had of diagnosing this was actually to examine the ovaries, take a piece of the ovaries out and examine them. But again, polycystic ovaries means that the ovaries tend to have lots of little cysts. Cysts are basically bubbles of fluid in them. These are normal. This is not cancer, not tumorous. Those bubbles actually contain the follicles, right? The eggs, if you would. They don't just, they're sort of hanging out there and creating this appearance to polycystic ovaries, and we'll talk about that as well. But these are the 3 principal features. Now, when you think about it, and this is a slide that may be a little bit complicated, but there are many different type of diagnostic criteria. Is the NIH 1990, which calls for 2 groups of patients who have excess male hormone effect, either hirsutism or androgen excess, or both, ovulation dysfunction, irregular ovulation, and may or may not have polycystic ovaries. These are what we call classic PCOS. Rotterdam 2003 expanded the definition, added 2 different phenotypes, women who have excess male hormones, polycystic ovaries, but really have regular ovulation. And these are what we call phenotype C, as you can see, or commonly is called ovulatory PCOS. And finally, there's a group of women, which we call phenotype D, which have irregular ovulation, polycystic ovaries, but really don't seem to have evidence of excess male hormones. These are what we call non-hyperandrogenic PCOS, and this tends to be a little bit the more controversial part of the more controversial presentation of PCOS. But again, this is called classic. These 2, A and B, are classic PCOS, which it means excess androgen effect or measurements, irregular ovulation with or without polycystic ovaries, ovulatory PCOS, and non-hyperandrogenic PCOS. Now, it's important to always remember that because PCOS is a syndrome, there's not one test that tells you that you have PCOS. You have to exclude other disorders. So your doctor should actually perform a series of tests to make sure you don't have something else, right? Adrenal hyperplasia or thyroid dysfunction or hyperprolactinemia. These kind of things are very common can sometimes mimic polycystic ovary syndrome. So we always say a PCOS is a diagnosis of exclusion and requires additional blood testing. Now, let's talk a little bit about menstrual dysfunction as a marker for ovulatory dysfunction in PCOS. As I said to you before, we generally are looking at menstruation as a reflection of ovulation, right? So regular vaginal bleeding in general tends to predict regular ovulation in women who are not hyperandrogenic. And this is what we often call menstrual bleeding, right? This regular vaginal bleeding. Now, the presence of premenstrual symptoms, swelling, breast tenderness, mood changes, etc., before the onset of vaginal bleeding may be helpful to suggest that the person did actually ovulate. A menstrual cycle is defined as the period of time from the beginning of one beginning of one bleed, if you would. That's what we call day one of the cycle, to the beginning of the next. That's the menstrual cycle. And again, we're assuming, right, that patients who have vaginal bleeding in a regular pattern are actually ovulating. Now, menstrual cycles normally last somewhere between 25 and 34 days, and cycles that are either shorter than that or longer than that are considered abnormal, and that's how we define menstrual dysfunction, what we call often illegal or anovulation, illegal or amenorrhea. Now, the issue is that in women who have excess male hormone effects like hirsutism, regular vaginal bleeding doesn't always predict regular ovulation. And so it's important if somebody comes in and has presence of, hair growth and so on and so forth, which we'll talk about in a second, if they seem to have regular periods, we have to confirm that they actually have ovulation. Now, hirsutism is one of the most common markers of polycystic ovary syndrome. Not all patients have it, right? Not all patients demonstrate this, but about 70% of patients with polycystic ovary syndrome, depending on ethnicity, will have hirsutism. And hirsutism is the presence of male-like hair growth throughout the body. These are examples here on the upper lip, right? You start seeing some of this in the upper lip. This is a score of 1, just very mild. This is a score of 4, very severe. And same thing on hair growth in lower abdomen. Score of 1, very mild, lower abdomen. Score of 4, fairly severe. So hirsutism is this male-like hair growth, and we tend to use this modified Ferriman-Galloway score system. It's a visual system to score the amount of hair growth an individual has, right? If you don't have any hair growth in these areas, then you are left blank. And if you have a lot, it's 4. And if you have minimal, it's 1. And of course, it's a subjective. So we rate 9 body areas for this excess hair growth: the upper lip, the chin and neck, the upper chest, generally in the midline, because it's normal to have hairs around the nipples often. Upper abdomen above the belly button, lower abdomen below the belly button, in your upper arms and your thighs, front and back, in your upper back and your lower back. And so that's what we tend to examine when we're looking for evidence of hirsutism. Now, what are polycystic ovaries anyway? And we use this as part of the name of the polycystic ovary syndrome, at least for now. But it incorrectly suggests that there are increased cysts in the ovaries. And the truth is that there are, those cysts are normal. They're just not progressing, which is why they sort of hang out, right? So we tend to accumulate more in this intermediate stage. These are dark areas, dark circles that we can see on ultrasound, but they are really follicles, really. They have eggs within them. So all of these little cysts that you see here, these are normal physiologic cysts that are really more evident in polycystic ovary syndrome women because they don't ovulate correctly, and so they grow to a certain stage and they stop, right? And these eggs have stopped developing partly along the way to ovulation. So again, polycystic ovaries are something that we see. We actually see them as well in women who do not have polycystic ovaries syndrome. And they don't indicate cancer or tumors or anything else like that. They are a reflection of the abnormal ovulation. Now, polycystic ovaries syndrome is associated with certainly long-term complications or morbidities. We'll talk a little bit more about why that happens, but it's associated with increased risk of uterine cancer because, again, many of these women don't ovulate correctly, and that tends to increase your risk of endometrial cancer. It tends to have metabolic complications, increased risk of diabetes, sugar intolerance, metabolic syndrome, gestational diabetes, a number of those things. It tends to increase also your cardiovascular disease risk. You may have increased risk of hypertension, of stroke, of heart disease, and so on and so forth. We're not going to get into that right now, but the point is that this is a disorder that affects way beyond just your skin, dermatologically, or your reproductive chances. It affects many other parts of your health. Now, as I mentioned, our group was the first to report on the prevalence of polycystic ovary syndrome. That means how many women in a population are affected with polycystic ovary syndrome. And until we did our first study in 1998, we actually thought that polycystic ovary syndrome was relatively rare. And so to our surprise, really, in our initial study, which was an incomplete study to be fair, about really 1 in 12 women had polycystic ovary syndrome in the general population we studied, and we were absolutely flabbergasted. And so immediately some colleagues, again, replicated our study. They confirmed our data. We did another bigger study and confirmed that data, and even then found that actually it affected 1 in 10 women with polycystic ovary syndrome. And so since then, we've either worked with groups or have been done independently across the world, and you can see the red dots, doing epidemiologic studies confirming, in fact, that the risk of polycystic ovary syndrome in a population is about the same across the world, about 1 in 10 women or so, somewhere between 1 in 5, 1 in 10, 1 in 7. It varies a little bit across the world. But what we don't have, and you can see from this map, is there are large chunks of the world that we don't know yet what really is the prevalence. What is the risk of polycystic ovary syndrome? Because we know it's genetic and we know that it varies according to different ethnicities. So, for example, Northern Canada, we don't have anything. Russia, we have almost nothing there. We just finished a study in Eastern Siberia. We have actually almost nothing in Africa. In fact, we have nothing in Africa, in Sub-Sahara Africa. But we just finished a study in Lagos, Nigeria there. We have nothing in Micronesia and very little in South America. We have an ongoing study in Colombia to try to determine this. And of course, we have very little to no data for the Caribbean. And this is really an area that has been very important to actually determine this. This is why you are here today joining us. Because again, Dr. Mohammed and colleagues have really undertaken a study to determine what is the risk of women in Trinidad and Tobago of having polycystic ovaries. Now, what causes polycystic ovary syndrome? Well, polycystic ovary syndrome is a disorder in great part determined by genetics, by your inheritance. The environment, what we eat, how overweight we are, environmental toxins, etc., do play a role, but it isn't as great as the role of genetics. And it's something that, in fact, only epidemiologic studies like the ones we're talking about will be able to tell us. How much does the environment actually play a role in determining the risk of PCOS? So the hormones that we're going to talk about today are androgens, male hormones. As I said before, we're going to talk about 3 hormones: androgens, insulin, LH. Now, androgens are steroids, and they're the so-called male hormones, although to be fair, both men and women produce androgens. Androgens have a lot of good effects, including helping individuals have healthier bones and muscles, increased energy, increased sex drive. So you want to have androgens, and you want those androgens because they actually are part of your healthy profile. Now, when they're present in excess, too much of a good thing, as I say, in women, androgens can cause symptoms such as increased male-like body hair growth, irregular cycles, and at times acne and scalp hair loss. This is called androgen excess or hyperandrogenism, and women with PCOS produce more androgens than women without polycystic ovary syndrome. So androgens play a key role in polycystic ovary syndrome. The second hormone we're going to talk about is insulin. Insulin is produced by the beta cells in the pancreas. Insulin helps parts of the body, for example, the brain, use sugar, what we call normally in science glucose, right? The principal energy source. And most of our food eventually gets converted into either fat or sugars, right? And those are the ones that are used by your body. And in fact, insulin regulates also the levels of fat, the utilization of fat by the liver and by other body tissues, and also stimulates some tissues to grow, like the theca cells of the ovary. These are the cells in the ovaries that produce male hormones, or the deeper layers of skin cells, and we'll talk a little bit about that in a minute. Now, if insufficient insulin is produced, individuals basically become diabetic, right? They cannot process their sugars and their lipids as well as they should. And alternatively, if the body does not respond appropriately to insulin, requiring more insulin than usual to keep their glucose levels normal, then we call these individuals insulin resistant. And many women with polycystic ovary syndrome, in fact, about 80% of them are insulin resistant, meaning they don't respond as well to their insulin, which means that their pancreas has to produce a lot more insulin to keep the sugar levels normal. And so women with polycystic ovary syndrome tend to have insulin excess, something we call hyperinsulinemia. And this is what happens when you have too much insulin. So you can see this darkness around the neck, axilla, and so on and so forth. This is called acanthosis nigricans. And this happens because the person is producing way too much insulin. That insulin stimulates the skin cells to grow and to cause this darkness. Now, this is very soft. This is not a coarse darkness. It's actually a very sort of velvety darkness. But again, this is something that you'll see in many individuals who are insulin resistant and produce too much insulin. Now, there is a relationship between having too much insulin and menstrual dysfunction. Remember that menstrual dysfunction, reflecting ovulatory dysfunction, is one of the key features of polycystic ovary syndrome. And the more severe, this is a study, and we don't have to get into the details if it's one of our studies, the more severe the insulin resistance is, the more severe the abnormality and menstrual dysfunction is. So individuals who don't menstruate at all really are much more insulin resistant in general than individuals who menstruate more regularly. Now, the last hormone we're going to talk about is LH. LH is called luteinizing hormone. It's produced by the pituitary gland in the brain. LH is secreted in a pulsatile fashion, so it's released about every 60 to 90 minutes. It pulses. And it plays a key role in regulating normal ovulation. That pulsatility is really important. It changes, becomes faster at the time of ovulation. Now, LH also stimulates the theca cells in the ovaries to produce androgens. As I said before, theca cells are those cells inside the ovaries that produce androgens, male hormones. It's normal. Ovaries do produce male hormones normally, right? What you don't want is too much male hormone. So LH stimulates theca cells of the ovaries to produce androgens, and women with PCOS may have LH levels that are higher or more persistent than normal women. So how do you put all this picture together? Well, this is from a recent publication of ours, and what you can see is the following. If an individual is obese or has other abnormalities of either their fat tissues or their insulin action, what happens is they tend to have insulin resistance. And as I said before, a large proportion, the vast majority of patients with polycystic ovary syndrome will have insulin resistance relative to their weight. Now, that insulin resistance in polycystic ovary syndrome generally results in hyperinsulinemia, too much insulin, because in fact, the pancreas is working okay. It just has to work over time to produce too much insulin. This together with LH, right? Then produces and stimulates the ovary to produce excess male hormones. It also impacts on the liver. So this is a sort of a cascade that combines the insulin, LH, and androgens. So what are the symptoms and features? Well, you have increased androgens that actually play a role in increasing insulin and vice versa. These lead to immature ovulation, which is what causes the irregular periods and the polycystic looking ovaries. The androgens also cause excess hair growth, and the insulin causes the insulin resistance, and the insulin excess causes the increased risk of diabetes, heart disease, and so on. All of this affects, obviously, a patient's body image, self-esteem, depression, and anxiety. These are very important features in the disorder. The study we did many years ago looking at quality of life in women with polycystic ovary syndrome. And what we found is that actually and again, the lower the score here, the less quality of life, the more depressed the quality of life was. The two things that depressed the quality of life in women with polycystic ovary syndrome the most in our study was their weight, obesity. If they were obese, that tended to suppress their quality of life, how they felt about the quality of their life. And if they had excess hair growth, again, hirsutism impacts very negatively many patients with polycystic ovary syndrome. So it's important to address polycystic ovary syndrome as early as possible in order to not just prevent the long-term medical complications of polycystic ovary syndrome, but also to prevent, if you would, the quality of life impact that this has. Now, PCOS changes across the lifespan. As I said before, this is a lifelong disorder that is most evident. You can see it more clearly during the reproductive years. But again, it affects children, it affects adolescents, it affects women in their older age. Of course, the concerns change, right? At the beginning of your life, you're more concerned about reproduction and dermatologic issues, and toward the older age, you're more concerned about long-term health concerns. And it's a continuum. You know, you can have mild features of polycystic ovary syndrome, moderate features, or even severe features. A lot of that severity is associated with increasing weight, and again, improving your lifestyle, having a healthier lifestyle will actually help to reduce the symptoms of polycystic ovary syndrome. Now, can PCOS be cured? The answer is PCOS cannot be cured, at least not yet. And that's, of course, you heard from PCOS Challenge and Sasha Oti that is one of the goals that we have in the future. But right now, it's not possible. But what we can do is treat the symptoms and signs and help them to improve. So they are very eminently treatable. So education information is really critical to improve the knowledge, provide reassurance, and to help self-manage patients with polycystic ovary syndrome. And this is sort of what we're doing today, and we hope to do much more. There are lots of treatments for this that help manage the symptoms and help reduce the long-term risks of polycystic ovary syndrome. Now, what are the goals for management? Well, the key is that treatment must be tailored to each individual. What is most important to you, okay? No, it's not sort of, as I said earlier, a one-size-fits-all. Management goals should be to improve the psychological and emotional health of PCOS patients, to reduce their signs and their symptoms, to assist with fertility and improve pregnancy outcomes if that is their desire, and to prevent long-term health problems. So if we focus on improving the psychological, emotional health of patients with PCOS, we should note that depression, anxiety, sexual dysfunction, and eating disorders are much more common in women with PCOS than in other women. So it is important to monitor emotional health. It's very critical. So you can ask yourself, do you feel down, depressed, or hopeless? Have you lost interest or pleasure in doing things you usually enjoy? Do you worry a lot about the way you look? Do you ever feel guilty, depressed, or disgusted about your eating? These are all signs that perhaps you should seek some help for your emotional and psychological dysfunction. Now, you know, again, this is also common in people, so it's not just because you feel these things doesn't mean that you actually have a problem. But it is important to recognize that women with polycystic ovary syndrome do have a higher a rate of psychological and emotional health dysfunction. Be proactive, discuss your emotional health with your doctor and any other support. Now, lifestyle is how we live. And I can tell you that most of us, including myself, don't manage our lifestyle well enough. We don't exercise enough, or maybe too much. We don't really eat as healthy as we'd like, and so on and so forth. But lifestyle management is a very effective way to help reduce symptoms and to cope with some of these stressors and emotional stressors in PCOS. Now, to be clear, PCOS is a genetic disorder, primarily a genetic disorder that we are born with, right? So we have to understand that lifestyle management doesn't cure it, but it will help us address some of those symptoms. And again, includes being active, eating a well-balanced diet, and is very helpful in all aspects of PCOS. So we certainly recommend it, although it is hard to maintain, and it's not a cure-all, it doesn't treat all symptoms equally. Now, management is an important focus, but I want you to understand that not all women with polycystic ovary syndrome are obese. We often tend to have that image in our head that, oh, if I'm obese, I must have polycystic ovary syndrome. But actually, that's because most patients who are obese are also those that have the lowest quality of life, right? They are unhappy with themselves and they tend to seek medical care more readily. The truth is, when you do studies in the population, only about 40% or less, depending on what country you're looking at, of women with PCOS are obese. But if you are overweight, or if you're eating poorly, because again, you don't have to be fully overweight to eat poorly, weight management and diet management is going to be really an important part of your treatment. Lifestyle change includes healthy eating a balanced diet, limiting foods with added sugar, salts, and fats. Because remember, you're stressing the pancreas every time you add a lot of sugar. So try to cut down on the sugary drinks, right? But also have healthy, realistic diet goals. You can't become a monk and not eat anything, right? I mean, this is not the way to do that. You have to have realistic goals, but eat healthier. This is an important part of what we do, and we've done a number of studies indicating that lower sugar foods are actually better for you, even if it's the same calories. Physical activity, very important. Get you out, get you around, and so on and so forth. I'm told dancing is really good for you, but I'm a poor dancer. So again, I defer to you as to what activities you like to do. The first line of medical therapy is often combined oral contraceptive pills. And this is, again, given to you not necessarily for contraception, although that may be a benefit, but it helps reduce the androgen levels that are produced by the ovaries. Very important. And again, the type of pill that you're choosing has really modest impact. All of us choose a few pills because we have experience with them and we think they have less side effects. But the truth is that any pill is better than no pill at all. It's better, obviously, to try to use a low-dose pill to the extent you can, and it's beneficial for a number of things. Contraception, of course, but it improves your regular cycles. It protects the lining of the uterus from developing uterine cancer. It reduces excess hair growth, and it improves acne. It may have some side effects, headaches, increased blood pressure, and blood clots, but these are relatively rare. It's something that, again, it's in the risk of 1 in the thousands of individuals. So it's not a very common side effect, particularly blood clots. It's not something, nevertheless, that you need to be concerned about. In fact, on weight, some patients tell me they lose weight immediately as soon as they go on birth control pills. Others complain that it may affect their weight. But in general, my experience is in polycystic ovary syndrome patients, it actually improves their weight. Managing hair and skin problems, again, birth control pills, or contraceptive pills will be the primary therapy. But after about 6 months, or if it hasn't really helped, or if you are very severe, then what we recommend is to combine the oral contraceptive pill with an anti-androgen, a drug that controls the excess male hormone, things like spironolactone, finasteride, cyproterone acetate, etc. So some of these are available in your countries. And again, if you don't tolerate birth control pills or anti-androgens, there are other alternatives you should explore with your doctor. Now, how about cosmetic and topical therapy? These are critical. People should not dismiss them. Medical therapy will help you, but it takes time for it to help. And in fact, it won't make things like hirsutism disappear. It'll make it sort of less, but not make it disappear. So clearly you need to learn about how to treat excess hair growth, things like electrology, and eflornithine hydrochloride is a drug, but it's by prescription. Sometimes patients have scalp hair loss, although I should tell you that only 10% of women with scalp hair loss actually have excess male hormones. But again, things like minoxidil and so on can help. And again, treatment of acne. There are a number of different treatments that can be prescribed, or you can use things like over-the-counter treatments. Now, cycle irregularity is something that you want to treat when you are a patient with polycystic ovary syndrome. So lifestyle change, as I said before, can help. Combined oral contraceptives can also help, but can take them, continuously. Or sometimes you have to move to other things like cyclic progesterone administration, because that will help you, and particularly in women who don't tolerate birth control pills. Metformin is a drug that helps improve insulin resistance. It's an old drug. It's been used for diabetes. It helps improve ovulation cycles, but to be fair, only modestly. So it's not the answer all for everybody. It is used for, as I said, for diabetes for a long time. And it can be useful in PCOS by reducing insulin resistance, reducing progression to diabetes, may prevent weight gain, but it doesn't really cause significant weight loss, despite what people will tell you. It improves menstruation and ovulation somewhat, and has limited impact on fertility. Now, there are side effects, right? I mean, it's the GI side effects, nausea, vomiting, diarrhea, these kind of things are more common. About 20% of patients who take metformin will have these side effects. Vitamin B12 deficiency is something to watch for, although not very common. Lactose acidosis, also very rare as a complication, and it is contraindicated in individuals with severe kidney disease. Now, there are a number of alternative or natural therapies that are advertised, but I will tell you that the alternative medicine industry is not really strictly regulated. Many of the claims are not based on evidence. Many of the products are not tested for safety or efficacy. We're actually now doing a meta-analysis, a systematic review of meta-analysis of these potential therapies. Most research trials in alternative medicine either have very small numbers of participants or don't really compare the effect to something else, right? They just compare it to nothing at all. And that's not necessarily the best comparison. But I will say some of these therapies do work. It's just not known exactly which ones yet, because really we need better studies in this regard. Improving fertility is something that many patients come to us. About 70% of women with PCOS report difficulty getting pregnant. Unhealthy weight obviously worsens infertility and reduces effectiveness of any of the treatments for infertility. The older you wait, age-related infertility is a big issue. So one of the things that I always tell patients with PCOS is, if all things are the same and you are able to do so, try to become pregnant earlier than later. So that way you don't add your age-related factors to your PCOS factors. But again, not everybody can decide to become pregnant early on in life. There are a number of medicines that are useful for causing ovulation. We won't talk about them today, but again, it's important. It's also important to remember that women with polycystic ovary syndrome do have an increased risk of various complications of pregnancies, including diabetes in pregnancy, high blood pressure in pregnancy, early delivery, larger babies. So it's important to discuss with your doctor when you're planning to get pregnant. Again, how do you minimize long-term health problems? Well, you focus on the prevention of risks, right? You focus on diet and exercise, lifestyle. You try to become healthier as an individual. Prevention of weight gain is vital if you can, but again, take it from me, it's a difficult, lifelong battle. Screening and prevention are critical. So if you have polycystic ovary syndrome, you want to be screened for uterine cancer regularly, for breast cancer, although breast cancer is not increased in polycystic ovary syndrome, but you want to be screened and have regular medical care. Metformin has a role in helping some of this, but we don't really know how good it is. So in conclusion, polycystic ovary syndrome is a very common long-term condition. Symptoms vary between women across the lifespan, although they're most evident during the reproductive years. Lifestyle management improves all aspects of PCOS to some degree, but is not actually easy for everybody. Monitoring emotional well-being and seeking support when needed is important for a good quality of life. There are some long-term health risks that can be prevented and should be prevented. Treatment can reduce symptoms and the risk of complications. PCOS patients often do not find ready and quality medical evaluation and management for their disorders. In fact, many women with polycystic ovary syndrome have to see 4 or 5 physicians before somebody actually pays attention to them, or before they find somebody who actually knows about polycystic ovary syndrome. And this is something that we are trying to address. And finally, support is available and education is important. You heard Sasha Oti speak earlier. And again, there are a lot of other organizations that can help locally or otherwise. So please remember, you're not alone. Support is available, and you have to become educated about this. Be careful about being educated on the web unless you're actually being educated by reputable sources. Thank you very much, and I appreciate your attention.
Thank you very much, Professor Aziz. Thank you for that enlightening presentation. And as you would imagine, with such an informative presentation, there would be associated questions. So I now invite the moderators to delegate the session to both Professor Aziz and Ms. Sasha. So you can type your questions into the chat box. And if it is you would like to unmute your mic, you can just show by the raise of a hand and then we will unmute you. So moderators, you can go ahead.
Hi, good afternoon, good evening, sorry. Professor Aziz and Ms. Oti, thank you so very much for those enlightening presentations. We do have a number of questions. Some of them were asked in advance of the session, and most of them were covered. So the ones that weren't, we have one. Can PCOS develop during perimenopause?
Can PCOS develop during the menopause? Is that the question?
During perimenopause.
So polycystic ovary syndrome is a lifelong disorder. It is mostly genetically caused, so it starts at birth, right? And so it's present throughout life. It is unusual for individuals to have a perfectly normal reproductive life, no excess hair growth, no irregular periods, no polycystic, no nothing, and then all of a sudden develop symptoms in the perimenopause. Usually when women are developing irregular periods, lots of cysts on their ovaries, these kind of things in the perimenopause, that really is a reflection of the perimenopause itself. Because as you shift from a normal reproductive function to menopause, that period of time, there's a lot of abnormalities. So the short answer is PCOS should not express itself for the first time in the perimenopause. That'd be relatively unusual.
Thanks for that, Professor. The next question is, what are vitamins or mineral deficiencies associated with PCOS, if any?
Let me have Sasha take a swing at that, and then I'll fill in.
Okay, could you please repeat the question?
Certainly. What vitamin or mineral deficiencies are associated with PCOS, if any?
Yes, there are some, and I would suggest if anyone, and this is something that I tell everyone, if you do have access to a nutrition professional, such as a dietitian, especially those who are aware of PCOS or specialize in PCOS, please do so, because there's a very tight connection between nutrition status and PCOS. So many PCOS patients are deficient in vitamin D. So this is one thing that everyone should get checked. As Dr. Aziz mentioned, if you're on metformin, another deficiency to be aware of is B12. But there are many things that you as an individual could be deficient in, but I would suggest that you see a healthcare provider, especially a dietitian or nutritionist.
Sasha is absolutely correct. There is no one specific vitamin deficiency associated with PCOS. There have been some studies suggesting, as Sasha said, a vitamin D deficiency may be associated with PCOS, but the reality is that the data is still wanting and we have to do better studies. But again, it is important as part of your nutritional plan and a part of your lifestyle management that you understand basically your own personal nutritional profile.
Thank you. Another question, can weight loss and maintenance coupled with proper diet resolve PCOS, or is medication the only solution?
So again, there is no such thing as resolved PCOS. Patients will have PCOS, right? It's a lifelong disorder. It's like any other disorder that we tend to live with. That's a chronic disorder, right? Whether it's hypertension, high blood pressure, or glucose intolerance or diabetes, etc. But lifestyle and management will ameliorate, will reduce the symptoms and make people feel much better. Now, it may not resolve all of them, so it's unusual to be fully resolved only on diet and exercise. For example, hair growth will perhaps improve a little bit, but may require more medical therapies, for example. So lifestyle and lifestyle management is certainly a positive thing. Will improve lots of the signs and symptoms. Will make the psychological and emotional health improve as well. But it doesn't really take away everything. And I just want everybody to be clear on that. Sasha?
Yeah, I do think that just not everyone with PCOS has weight issues. And
Right.
in fact, people, there were a few questions that were directed to me in the chat today. There are people with low BMI who have PCOS. So weight loss is not really the only solution. And those people feel like they're at a loss because they don't get advised on how to manage the condition. So one approach is to make healthier lifestyle choices based on your own individual situation, and with weight loss not being the solution for PCOS as many will have you believe. So I think it and PCOS requires an individualized approach. Each of us have it's a spectrum. It's a disorder. It's a symptom, which is a constellation of symptoms. So you can line up 10 people with PCOS, and we'll each have different forms of the disorder. So again, and it's unfortunate that there are so many people, so many healthcare providers who are not well informed about PCOS, and we're trying to change that by raising awareness and educating the general public, like what you're doing here, but also dedicated efforts to educate healthcare providers as well.
Thank you. We have a 3-part question. Can you share your experience with pro-inflammatory foods and its contribution to this condition? That's it. Would you like me to read all 3 parts, one after the other?
Let's answer one at a time, if you don't mind. So inflammatory foods, as I said before, we've actually done some studies. There's others, dietary studies, but we've done studies that, in fact, the low glycemic food seems to improve the insulin and the inflammatory profile of patients with PCOS. Having said that, as I said before, lifestyle management is important to consider, but it isn't a cure, right? And as Sasha said, lots of people are actually eating healthy and have a good weight, and actually they still have polycystic ovary syndrome because it is actually a genetic disorder. So yes, there are foods that will tend to be pro-inflammatory, pro-insulin resistance, and those tend to be the high glycemic foods, the high fatty foods, right? Fried foods, those kind of things. Those tend to be, not healthy. When I say high glycemic, we're talking about breads and pastas, a lot of the things that we all like to eat, like potato chips and so on and so forth, right? So yeah, those things do make the condition worse or the complications worse. They're not a cure. Sasha?
Yeah, I agree. And it's like I said, nutrition, of course, is intertwined with PCOS management, and we each just respond differently to different foods. So I think the general rule of thumb, and importantly to note, there is no one diet that that manages PCOS for everyone. So there's no one diet that's recommended for each one. So and Dr. Aziz could go on a low sugar diet, or you could recommend someone go on a low sugar diet and someone else will go on a Mediterranean diet, whatever it is that works for you. And there's unfortunately a lot of trial and error in this space to figure it all out.
Thank you, Ms. Otti. Especially thank you for making mention of that diet, because we had a number of questions, persons asking about what is a recommended diet for persons with PCOS. So the second part of the question would be, what would you consider to be appropriate screening in context of being cheap and easily accessible for large numbers of patients for this condition?
So we spend a fair amount of time in our with our team trying to actually determine that question. And I can tell you that, two clinical questions are highly predictive of polycystic ovary syndrome. They're not enough to diagnose it, but are highly predictive. So if you ask two questions, you ask patients, do they have irregular periods, right? Not just occasion, but do they have a history of irregular periods, yes or no? And do they have unwanted body hair or facial hair growth? Yes or no? Those two questions are sufficient to identify individuals who are at higher risk for polycystic ovary syndrome. Yes to either one of those two questions, okay? It has about an 80% predictive ability. And so that's one way to identify individuals who are at high risk for polycystic ovary syndrome, who then should be evaluated. And their evaluation can include a physical exam, important, right? Physical exam and an ultrasound, perhaps. Not everybody does need an ultrasound, and blood testing for certainly the exclusion disorders, right? TSH, prolactin, 17-HB. Does everybody need male hormones? Well, not really. If you, for example, have excess, hair growth, if you have hirsutism already, the excess male hormone levels won't tell you very much. So the principal hormones that you would be looking for is these exclusion-related hormones. That's the simplest way to approach polycystic ovary syndrome, in my mind, from a diagnostic point of view.
And Dr.
Sasha?
If I may add, and for those who don't experience hirsutism, some people may experience severe acne. And so I had someone ask me earlier, as a lean woman with PCOS, her most problematic symptom is the acne, severe acne. And Dr. Zila, do you realize that this happens a lot in lean PCOS women? Acne is one of the most bothersome symptoms.
Yeah, and so in our studies, actually about 30% of PCOS women will have acne. Very often, acne and PCOS is actually combined with hirsutism. So the proportion of women with PCOS, at least in our studies, that have acne only as a sign of androgen excess is only about 10%. But it is true. It does appear, and it tends to be, as you said, in leaner, younger women. And the reason is that they tend to have more elevated adrenal androgens, right? These are other androgens. We talked about the ovaries. Adrenal androgens tend to be more associated with acne, and so it's important. But the flip side is, it's also important to recognize that not all acne is related to excess male hormones. And I think it's important that if, for example, person has acne, they're treated with birth control pills, and there's no improvement in their acne, that they need to understand that acne is also a local condition that needs to be treated locally. It's not just a hormonal condition. So you again, every patient needs to be examined appropriately by a clinician that understands these signs and symptoms. But you're right, Sasha. There are patients with polycystic ovary syndrome whose dermatologic symptom is primarily acne.
Is it okay with the moderators if I ask a question? This is a mostly Caribbean audience, correct? Would you mind in the chat posting a food that you really love as a person with PCOS maybe you're in Trinidad or Jamaica or whatever. What food do you love that you think is probably not that great for PCOS, but what you love? I know I like roti and I love dumpling, cheese patty, lasagna, bread, rice. Yes, rice is a staple across many of these islands. And this is an example of why we can't really just follow specific diets. How do you apply the Mediterranean diet to a Caribbean diet? So these are nuances that, and a lot of people are really responding. Chocolate, yes, doubles and roti. And when I do come to Trinidad, I will be having some doubles and roti.
And Sasha has me at a disadvantage because A, I don't cook, and B, I have the foggiest idea. I mean, I did live in Puerto Rico for many years, but arroz con gandules and so on and so forth is what I have. But beyond that, I am no chef. But Sasha, that is a good point. And that is the key. The key really is that PCOS is a global condition. It's a global condition, and we have to understand how the local geography, the local culture, the local custom and actually impact not just the disorder, but its treatment.
Yes, so I'm not saying you can't have roti, but have balance, right? Have vegetables with your roti, have some protein. So it's about balance, and it's not about living a boring life. So that's
I'll have
very
to figure
important.
out. Sasha, at a later time, you'll have to tell me what roti is. It sounds like you're very, no, not now. All right.
Okay, so thank you, Professor Aziz and Mrs. Sasha Uti. Also, thank you, Melissa, for delegating that session. This was a lovely Q&A session. I mean, I know that there are still many unanswered questions, but we can't actually sit here all night discussing PCOS. But as you are aware, we must close this. You can visit
Dr. Mohammed,
No, go ahead.
there was a really important question earlier, and I wanted Dr. Aziz to address this. Someone asked, her sister has features like larger clitoris, and there's certain things that certain disorders that are common, are closely related to PCOS that Dr. Aziz, I know you mentioned excluding, but I think that was a very important question to ask. Can you just address if this happens in PCOS and if there's anything else that they should look out for?
So it's interesting. So what Sasha is referring to are symptoms of what we call virilization. So virilization is when the levels of male hormone have been there for a long time and have been very high, particularly since childhood. So you end up developing, for example, an enlarged clitoris. You may develop, changes in your body fat distribution. You may have a more male-like body fat distribution. You may have larger muscles, these kind of things. You may have balding that is a male-like balding, right? Rather than the sort of diffuse balding that is common in women. So in general, we don't see that in polycystic ovary syndrome. I see lots of it because as Dr. Coburn said, I actually manage women with excess male hormones as well as polycystic ovary syndrome, even though polycystic ovary syndrome is the most common type. So those tend to be less common, Sasha. They have been reported in PCOS, but again, to do that, you have to have very high levels of androgens, if they are androgen related and if they're true, right? Really from childhood.
Yeah, so disorders such as non-classic adrenal hyperplasia.
Yeah, non-classic adrenal hyperplasia rarely can do that. Only about 5% of the non-classic adrenal hyperplasia patients have it, but you're absolutely correct. The other syndrome that sometimes causes it is syndromes of severe insulin resistance. So we've talked about PCOS having insulin resistance, but there is syndromes that are primarily about insulin action defects, right? We call these lipodystrophy, insulin resistance syndromes, so on and so forth, that have a secondarily a PCOS-like picture, but the primary problem is really severe insulin resistance that actually can present in childhood with excess male hormones then. So again, it isn't all simple. I wish I could just tell you a little bit, but certainly it's not a common feature in PCOS.
Okay, great. Thank you for that very important question, Sasha. And thank you again, Professor Aziz. To give the vote of thanks, I would now like to invite the representative from the Rotary District 7030 Advocate for Empowering Girls, Miss Maria Mohammed Maharaja.
Thanks very much, Stephanie. Ladies and gentlemen, distinguished guests and participants, please allow me to observe the previously established protocols. Tonight, we have witnessed the power of collaboration and the collective dedication to improving women's health with this remarkable event. And I mean, you can see from the questions, we still have more to respond to. And I'm sure what would happen is that we will send emails to everybody who can get their questions answered tonight. Our heartfelt appreciation goes out to our chair, Dr. Stephanie Mohammed, for her inspiring opening remarks. Her passion for women's health has been the driving force behind this event, and we are truly grateful for her unwavering support and guidance. I would like to extend our gratitude to Professor Dilip Dan for gracing us with his greetings on behalf of research and graduates. Your presence here tonight highlights the importance of academic research and its role in shaping the future of women's health. We are honored to have received greetings from Mr. Brian Glasgow, our Rotary District Governor. Rotary International's ongoing commitment to community service has made a significant impact on girls and women's empowerment, mental health initiatives, and fighting disease. And we are thankful for the support of Rotary. We would also like to express our gratitude to Rotarians and Rotaractors from District 7030 and 7020, which makes up the whole Caribbean, and other clubs who have joined us this evening. A special thank you to Mr. Andrew Dano and the Diabetes Association of Trinidad and Tobago for sharing their greetings with us. Your efforts to raise awareness about diabetes and its connections to PCOS are commendable and vital for holistic healthcare. Our gratitude also extends to Dr. Sundaram and Dr. Brian Coburn for the introduction of the speakers. Your kind words set the stage for the insightful and impactful presentations we viewed. Dr. Sundaram and Dr. Coburn are the main supervisors for Dr. Mohammed in assessing the prevalence of PCOS in Trinidad and Tobago. With their help and support, this research and seminar was made possible. And we are deeply honored to have Ms. Sasha Otley, the founder of PCOS Challenge, among us today. Your tireless dedication to raising awareness about PCOS has been a beacon of hope for countless women. Your journey has inspired us to be advocates for women's health, and we thank you for sharing your knowledge and experiences. And of course, we express our sincere appreciation to our guest speaker, Professor Ricardo Aziz, for his enlightening talk. Your expertise and research in the field of women's health have undoubtedly advanced our understanding of polycystic ovary syndrome. Your insights will undoubtedly pave the way for better care and support for women across the globe. The interactive session with Professor Aziz and Ms. Otley was enlightening, and we thank them for addressing the questions raised by the audience. Your willingness to share your experience and expertise has enriched this event beyond measure, and to highlight that both Professor Aziz and Ms. Otley are working with Dr. Mohammed, Dr. Sundaram, and Dr. Coburn on this project. Our sincere appreciation to the Marketing and Communications Department of the UE for their exceptional efforts in promoting and publicizing this event. Their support has played a pivotal role in reaching a wider audience and raising awareness about PCOS. Additionally, we thank the faculties of Science and Technology and Medical Sciences for their collaboration and endorsement of this initiative. Your academic expertise and commitment to advancing women's health have been invaluable. We extend our gratitude to our sponsors, that is PCOS Challenge, the National Polycystic Ovary Syndrome Association, Rotary Clubs of Central Port-of-Spain, Felicity Charleville, and St. Augustine, Rams Logistics, Caribbean Eye Institute, and the Diabetes Association of Trinidad and Tobago. Thank you for standing with us in advancing women's health. Your sponsorship has truly made a difference, and we look forward to continuing our journey together. And of course, a special recognition goes out to the women in the video who bravely shared their personal stories about living with polycystic ovary syndrome. Their courage and willingness to speak out have amplified the importance of spreading awareness about this condition and provided hope to others facing similar challenges. To all participants who have joined us tonight, we express our heartfelt gratitude. Your presence and engagement have made this event a true success. Each one of you plays a crucial role in advancing women's health, and we encourage you to carry this momentum forward from this evening. As we bring the event to a close, let us not forget the importance of continued collaboration, research, and awareness in our pursuit of better healthcare for women with polycystic ovary syndrome. Let us strive to create a world where every woman receives the care, understanding, and the support she deserves. Thank you once again for being part of this evening. We hope that the knowledge shared and the connections made tonight will have a lasting impression on women's health. May we move forward with renewed determination and a shared commitment to make a difference in the lives of women everywhere. Together, we can truly advance women's health and create a brighter, healthier future for all. Thank you, and I now pass you over to Dr. Mohammed.
Thank you, Maria, for that lovely vote of thanks. And I would also like to highlight marketing and communication who are from the St. Augustine campus here at the University of the West Indies. Thank you very much for assisting us with the live streaming. We are live streaming right now on our Facebook page. And also this here is a list of the various countries that are in attendance tonight. So thank you all very much. That's it. Also, if there are any more questions, please feel free to visit PCOS Challenge, where you actually speak to Ms. Sasha Uti. The link is already placed in the chat. And yeah, thank you all very much. And have a good night.
Thank you very much, Stephanie.